Welcome everybody to the final session of the Immunization Coalition's 2022 annual scientific meeting. It's been a good one yet again. This session we have another 3 expert panelists to discuss vaccine safety, side effects and therapeutics. Our first talk in this session is on vaccine safety, and it's from the renowned Professor Christine Mccartney, Director of the National Centre of Immunisation Research and Surveillance in Australia. She's been an infectious disease specialist for a very long time. She's got tremendous experience in the field of vaccinology. She's a founding member of the US Vaccine Education Centre and the senior editor of the Australian Immunisation Handbook, and consults to ATAGI in many and different ways. Christine has a clinical appointment at the Children's Hospital at Westmead as a staff specialist in infectious diseases and microbiology. So good to have you again, Christine. Thank you for talking.
Well, thank you very much for the opportunity to discuss COVID-19 vaccine safety with you today. I'd like to start by acknowledging the traditional owners of the land on which we're all variously meeting and pay my respects to Aboriginal and Torres Strait Islander people across Australia. So I'm going to talk a little bit about some vaccine safety concepts before we get into data. And of course, we know vaccine safety is paramount. The vaccines are given to protect against disease, not to treat it. So they're held to the highest safety standards, and benefits must outweigh risks. But of course, we have to think about those benefits and think about the risks of the diseases that we're preventing as well. And also a poignant reminder of what an AEFI is, which is our sort of terminology in vaccine safety. It's any untoward medical occurrence which follows immunisation, and which does not necessarily have a causal relationship with usage of the vaccine. So remember that. We often think, oh, it came after, therefore it's caused by. But we're looking for anything that comes after. It may or may not be caused by the vaccine itself. In fact, the World Health Organization categorises AEFI into 5 helpful categories, and these always are good to think of. Something could be vaccine product related. We'll remember febrile seizures with the CSL Fluvax in 2010. It could be a quality defect in vaccines. Luckily, this is extraordinarily rare. Or immunisation error related. For example, giving a live vaccine to an immunocompromised patient, or injecting a vaccine in the wrong location. The 4th category is pretty interesting, an immunisation stress-related response. And, this is actually something that probably occurs much more often than we recognise. Not just fainting, but sometimes, presyncope and other types of reactions that, sometimes at their worst can even mimic anaphylaxis. And then coincidental, well, fall off a bike seems obvious, but coincidental can also include conditions that may themselves rarely be attributed to vaccination. So things like Guillain-Barré syndrome occurs every day in Australia, across the world, but we'll talk about that in vaccines in a minute. So the concept of things occurring coincidentally is brought in by this graphic, which talks about the background rates of adverse events. We all know bad things happen every day, and we then know from clinical trials what the expected rates of vaccine reactions are, and then we think about this concept of excess vaccine, adverse events, things that might be unexpected or attributable to the vaccine. These might be known or unknown. So just a word out about vaccine design and manufacture. Incredible efforts by the manufacturers, by all the steps in the regulatory process and monitoring process. But of course, we also have the introduction of novel vaccines and require alertness to the possibility of new effects. And a little bit of a mention about vaccine causality assessment, because I think that this is a complex area. Very few adverse events that occur, as I've already alluded to, have a unique profile that says, hey, I'm related to the vaccine. I'm not related to any other possible cause. And remember, many of the events that we might be thinking about are events that we don't normally know what the trigger is anyway. For example, autism, long time looking for a trigger. It's not vaccines, but, we have to think about how can we then use science, both mechanistic, epidemiological, biologic science, and then deep clinical understanding of each individual patient, or epidemiologic studies to understand causation. And there's a lot written and available in training about this. So I just wanted to emphasise that, the way that we examine this is quite complex. And of course, with COVID-19 vaccine rollout, we're seeing considerable efforts that have been undertaken across, all of the 200 or so countries that we've got in the world to improve AFI surveillance, whether that be through improving passive surveillance, which of course still only gets one of these 4 boxes, the got vaccinated, had an illness. So we do need other modalities like active vaccine safety surveillance in different types and forms to really assess vaccine attributable risk. What's also important, of course, is this cycle of doing post-marketing safety surveillance, looking for AEFI, notifying them, investigating them, analysing data, doing more studies often, doing causality assessments or risk assessments in population data, and then feedback and corrective action. So, of course, this has the potential to improve program safety, to improve program settings, but in doing so, it also can improve confidence in vaccines and vaccine uptake. And this graphic, we've all heard this, haven't we? Factors influencing perceptions of COVID-19 vaccine safety. They are out there. They're in practically every conversation we have about vaccines is about the safety of them. Sometimes about the efficacy or effectiveness as well. But absolutely critical that this is, our top priority. And I'm really pleased to say, as you can see here from the WHO COVID Safety Manual, and the incredible efforts of really hundreds of thousands of people across the world, I'm sure, all participating in vaccine safety surveillance. So I don't have time today to go through all of the data on safety of COVID-19 vaccines. There's so much from pharmaceutical company RCTs, from a number of other independent vaccine clinical trials, from post-marketing surveillance, both passive, active, and of many different types, and from these observational or epidemiological risk studies. But I'm going to give you this very wordy slide, which basically says that not only have cohorts been monitored where you follow up with them and say, well, what happened? Did anything happen? But these adverse events of special interest have been particularly monitored in a number of studies across the world. Ones that might be associated with the vaccine, not are proven to be, but might be. Could they be related to the platform? Could they be related to the adjuvant? Could they be related to the antigen itself? Or even could there be enhanced disease, which really has not come through from any of the vaccines at all. Have we seen vaccine-associated enhanced disease? Great news for the COVID vaccines. So a whole list of what putative, things to look out for have been under study. Coming back to this immunisation stress-related response, I wanted to really underpin that this can be significant. We talked about it being a vasovagal. We talked about, it mimicking anaphylaxis. There's even dissociative neurologic symptom complexes. All sorts of different, really complicated things can happen if this is not accurately diagnosed and appropriately managed. And a shout out to when this occurred in 2007 with HPV vaccines. So remember that, we know a lot about the safety of these vaccines now. One of the reasons I'm mentioning this is because a couple of interesting articles have just been published on the nocebo effect. So think about placebo, which is basically you think something happens even though you got a placebo, but think now about nocebo, which is a negative reaction characterised by the expression of adverse symptoms, largely driven by the expectation that untoward events might occur. So particularly now too, when we've got these last few people being vaccinated, really anxious about the safety of vaccines, many of them, really concerned about the potential for adverse events. One of the ways that the nocebo effect has been, I guess, kind of demonstrated here, or at least considered as being a possibility, is the high rate of adverse events in the control placebo groups, in clinical trials of COVID-19 vaccines. So you could argue, for example, that these very high background rates of headache or, muscle aches or tiredness of around 20 to 30% in some of the placebo arms could be just people experiencing those adverse events at baseline from the pandemic or they could be an expectation. And there's an interesting thing about whether this might, you might be on your best day when you go to have your vaccine because you want to be healthy. So we might see healthier people, but we're still vaccinating everyone mostly. So how these two factors counterbalance in the journey people have before and after their vaccine is really interesting. Okay, so what's important is that two significant adverse events have emerged. Myocarditis and pericarditis following mRNA vaccines, and this new syndrome, which we all know about, called thrombosis, thrombocytopenia syndrome after viral vector vaccines, and we're going to have a fabulous talk on that next, so I won't spend a lot of time on these. But again, remember that we're talking about the tremendous benefit and lives saved from COVID vaccines, so we want to put these in perspective. Okay, myocarditis, so lots of information out there, and I would commend to you the weekly TGA safety report. It's really detailed. It is data from spontaneous reporting. So remember, not everything reported will be caused by the vaccine, but TGA, along with state territory colleagues and centres like our own, have been participating in a massive effort across Australia to characterise and classify all of the myocarditis and pericarditis cases. And here are the rates that you can see for Pfizer vaccines and Moderna vaccines, the two mRNA vaccines used from 12 and above in Australia. It's in the report, I think, of the 27th of January. So we know the risk here is mainly in adolescent and young adult males, mainly after the second dose. It's not to say it doesn't occur in females, but this is where we see the highest rates. And we're looking here, if we'd say focus in on where the most cases have been occurring, in males, around 1 per 10,000 here for, post second dose with Pfizer, and around 15 per 10,000. So, sorry, I'm confusing you. 1.5 per 10,000. I'm giving you the 10,000 instead of the 100,000, or 15 per 100,000 for Moderna. Now, this is very interesting because some studies using Pfizer and Moderna from other countries, like the Nordic countries and indeed from Canada, have suggested more like a 2 to 5-fold higher rate with Moderna compared to Pfizer in this age group. In Australia, it's tracking along around this 1.5 times rate. But nonetheless, that information is available in the TARGI guidance around the modest differential, albeit still very rare, for both mRNA vaccines to cause myocarditis. The rate post the third booster dose looks lower. There's good data from Israel, which I don't have for you in a slide today, but reassuringly across age groups, the rate of myocarditis after the booster dose looks lower as compared with the second dose. In fact, either around or a bit lower than the first dose. And there have been very few cases of myocarditis reported in children aged 5 to 11 years in the US. I wrote there about 2 per million, but I've got another slide on that. Now, this is the latest published data from the United States, presented at an ACIP meeting in early January. And the reason I'm showing you this is because this is not the spontaneous reporting system in the US. This is now a linked data system they called the Vaccine Safety Data Link. It's a cohort of people across about 9 health maintenance organisations that adds up to around 9 to 10 million people. So not the whole of the USA, but a very detailed analysis, and they've done a whole range of adverse events of special interest, but most of which are not flagging as signals. Looking at different time intervals post-vaccination, so a control period in vaccinated people, because of course, comparing unvaccinated people, they might not present to healthcare, there's differences, and vaccination rates are pretty high. We look across and we say, well, what here is the excess risk? So if you move right over to the risk column and we focus in, say, on the 0 to 7 days, because really the peak time to get myocarditis is right on day 2. So focus in on the 0 to 7 day period, bottom right-hand 3 squares, and you see that the total risk here after either dose is around 34 cases per million. So, 3 per 100,000. But if you then focus in on dose 2, it's more like, 70 per million or 7 per 100,000, which is around 1 in 14,000 post-dose 2. And this is in 12 to 17-year-olds, I should say, and this is with Pfizer vaccine. They're not using Moderna in under 18 in the United States. So a very similar rate to what we've been seeing as reported here in Australia. But remember, this is not all reports. This is now excess risk. So it's compared, subtracting away essentially that background rate. They've done a lot of follow-up. Again, this condition does knock some, young people around for a few months. They've got to be on a few exercise restrictions, might still experience some intermittent chest pain. Some might still be on medication, but it's been largely recovering and resolving. So relative to the usual myocarditis, it certainly is mild. And relative to what we see, for example, from COVID itself, where we know myocarditis is more common, the balance is there. And similarly, I think I've got the rate here of myocarditis in children 5 to 11 years. Really no concerning reports here. A couple of cases that look like they could be in that typical period. Okay, so we do expect less vaccine-associated myocarditis in younger ages in the 5 to 11 years because as a background rate it occurs less often, and there is good guidance on this from ATAGI. And just as a note, having been doing some clinical duties lately and seeing a number of cases of PIMS-TS, which we have really good risk estimates of from last year with Delta, with 1 in 3,000 COVID positive children in the state of New South Wales experiencing PIMS-TS. That occurs and includes inflammation of the myocardium, so myocarditis, a higher risk than vaccines. Okay, so quickly, I'm sure you're familiar with AusVac Safety. Not only is it an active participant-based cohort event monitoring system, which I'll show you some slides of, but there's also our AFI Clinical Assessment Network and a long-term follow-up program of research collaborating across all of our wonderful states and territories, the TGA and specialist groups. And then we're beginning some new work in linked data. So here's the active surveillance. 5.5 million people surveyed surveys done after COVID-19 vaccine doses. Quite an incredible number of people tracked, broken down by Aboriginal and Torres Strait Islander, adolescent, children, pregnant participants, people affected with cancer, chronic risk conditions, and so forth. And you can see their expected rates of adverse events within the first 3 to 8 days. Very few people needing medical care, needing to visit a GP or an ED, very comparable to other vaccines that we use. And again, we're not saying this is from the vaccine, we're saying this is what occurred after the vaccine, so not all of these adverse events experienced will necessarily be caused by the vaccine. Here's the data, for example, on Pfizer, monitoring booster doses as well. You can see the breakdown, how many people missed work, for example, or usual duties. And this was important in early days in the pandemic once we were getting to know the vaccines, but gives a continuous update on the website. All of this data is publicly available. Children, of course, 5 to 11-year-olds, more than 20,000 in public reporting now. Overall, children are tolerating the vaccine better than older adolescents and adults, young healthy adults. So reporting fewer side effects, not needing much of a break from their usual childhood duties, and doing really well with COVID-19 vaccines by every measure across every country that we've been, linked and linking with. Okay, so I think I've repeated the Pfizer dose here. I won't spend a long time on this slide, but I just wanted to, and it's quite small for you to see, but it's basically the relative odds of experiencing an adverse event after, or reporting rather, an adverse event after your COVID vaccine in these first few days using AusVac Safety. So if you go across the top, for example, and you can see relative to the 20 to 29-year-olds, those who are 30s and their 40s will report a few more adverse events. Those who are younger tend to experience less adverse events than those in the middle age groups. And then you can see those with medical conditions do tend to have slightly high rate of reporting of events. Of course, these may be background events because they have existing medical conditions, and this does vary a little bit by vaccine. So quite a lot of detailed data that can be gathered. And then, as I mentioned, we do have a follow-up program of research looking at TTS, looking at myocarditis, with initial surveillance, follow-up from hospital discharge and recovery, some epidemiologic analysis, long-term outcomes, and linked in biologic research. And really like to give a huge nod to both the Thrombosis Hemostasis Society and the Cardiology Society, who've worked so collaboratively with many people in immunisation and public health around and cared for patients with these adverse events. Okay, so just a few minutes left, and I think importantly, we've got new vaccines coming, we've got new schedules, we've got new populations, we've got mixed schedules. Novavax is about to roll out into Australia. It's a spike protein vaccine with a novel, not used in human populations before, adjuvant called Matrix M. And there's quite a bit of published RCT data from the company, but I thought I'd show you this study, which is an independent study. And in this study, even though, importantly, Novavax is registered for a primary dose, it's not registered yet as a booster dose in Australia, nor recommended as such by ATAGI. This study did include the third dose as a booster dose for Novavax, and you can see the systemic reactogenicity does increase. Reporting of this increases with each subsequent dose, albeit a sort of fairly expected level when you compare this with other vaccines like mRNA vaccines, for example. But definitely, the third dose packing a little bit more of a punch there. We'll see how this vaccine comes along, but I think it's important. People will ask, of course, is it associated with myocarditis? Is it associated with TTS? I think the technology is such that we don't expect it to be associated with TTS. We haven't really seen that with mRNA vaccines at all. But there were a couple of reports of myocarditis in the clinical trials. So we can't say it's not associated with myocarditis, and post-marketing surveillance will tell us. Just about mixed schedules and safety, there's an enormous amount of sort of immediate reactogenicity data that's available from clinical trials, a number of clinical trials, and a huge shout out to the UK group who've done the COV Boost study, an incredible consortium with a number of studies and the most dazzling array of these really cool plots of adverse events percentages, depending on which booster was given after a primary series of either Pfizer or AstraZeneca vaccine. So, it's mind-boggling how many 7 booster doses that they've used. But this, together with the immunogenicity data, has given us a really good insight into, boosters, albeit not that longer-term follow-up, but we have that from other studies. So, in summary, I thought I'd just end with a slide that talks about what we have seen linked with vaccines, because I could list a whole bunch of things that you're going to ask me. Oh, what about this and this and this and this? Well, we really don't have convincing studies, epidemiologically or causally, biologically plausible sort of mechanisms that link other conditions. But anaphylaxis we know occurs around 5 people per 1 million doses of certainly mRNA vaccines. GBS, there's been a signal, and it's only barely a signal. It seems pretty rare that we don't have really good population attributable estimates yet, and it appears more after viral vaccines. So very rare, and should not be a reason if someone's had GBS in the past not to get the vaccine, because GBS can occur with infections and COVID as well. The new thrombosis thrombocytopenia syndrome, and then ITP has been linked with AstraZeneca vaccine in a Scottish study with a risk of about 1 excess case per 100,000. And there has been an ITP-related death occurred in Australia. But again, not many studies coming out with a linkage here. So it may be that this is more of a spectrum, for the AstraZeneca or viral vector vaccines, which of course we're not using as much of now. Some great additional reading, which I won't go into, but vaccine safety is a magnificent science in its own right, and I think it's incredibly important that we do, learn as much as we can from the pandemic, and indeed communicate really how much is going on in this space. And shout out to everyone who's involved in that, and thank you very much for listening today. I look forward to participation in the panel. Bye bye.
Thanks again, Christine. That was just great. The next presentation will discuss TTS, thrombosis and thrombocytopenia syndrome, and I want to welcome Associate Professor Anup Enjeti. He's a physician and a specialist haematologist. He's got training across India, the UK and Australia, and his specialist training is in genetics and molecular genetics, where he's contributed to many high-impact publications. Really good to have you today, Anoop. I'm really looking forward to your presentation. Thank you.
Hello, and thank you, Robert, and thank you very much to the Immunization Coalition, which has invited me today. I am here to talk about a serious complication of COVID vaccination, the thrombosis and thrombocytopenia syndrome. So the objectives of this talk are to just understand and have a perspective of these serious complications, and including the diagnosis and an approach to diagnosis for these patients, and some of this can come up in the Q&A session later. But my focus is going to be on how we developed a pathway for early recognition and management, as well as the complications presenting as CVST, or the cerebral venous sinus thrombosis. There's a lot of abbreviations that people have used, and I've given a perspective of each of those, and they're all used interchangeably. And the one that we use most commonly now is called the thrombosis thrombocytopenia syndrome, and it's favored by a number of agencies because it doesn't specifically reference any vaccine association. The reports regarding thrombosis and thrombocytopenia syndrome started being published early 2021, and several groups have published on this since then, and they became to be recognized as a serious complication of the ChAdOx1 COVID-19 vaccination. And if you look at the data in Australia a few months after the initial reports were published, you can see that a number of serious complications arose, and these have been consistently reported by TGA, and these are the relevant figures as of now, with the reporting rate per 1,000 doses having gone down in the last year since the vaccination types changed within Australia. So currently we don't have any reported cases in the last few weeks following Christmas 2021. And you can also see that a number of cases that have accumulated over the last year or so range to about 147 after the first dose and 23 after the second dose of the ChAdOx1 vaccine. In contrast to this, if you compare it to the June 2021 data, we already had 60 patients in the first 3 months of the vaccination. So obviously the changeover to other vaccines later in 2021 has changed the profile and the occurrence of TTS. And if you look at the current fatalities of all these cases, there have been 8 cases who died, and all of them were after the first dose of the ChAdOx1 vaccine. I'll go through a couple of case reports, essentially covering the 2 major areas of diagnosis and management. So this is a 69-year-old male who presents 2 weeks after a bilateral total knee replacement to the John Hunter Hospital on regular usual medications such as aspirin and indomethacin, otherwise well. No particular history of bleeding, but has been exposed to heparin after his knee replacement, and no other real risk factors for any complications to expect. And then when we look at his blood counts, you can see that the platelets are really very low. The rest of the bloods seem okay. There's a little bit of alteration in the liver functions. And we had a heparin-dependent platelet antibody detected. And we diagnosed him as heparin-induced thrombosis and thrombocytopenia. We diagnosed this with a combination of clinical scores and the degree of low platelets. And this was confirmed by a test called serotonin release. The pathophysiology of thrombosis thrombocytopenia syndrome is very, very similar. Majority of the cases appear to have detectable antibodies to an antigen or a protein called the platelet factor 4. And it is similar to other prothrombotic immune-mediated thrombocytopenia, such as heparin-induced thrombotic thrombocytopenia syndrome. And that's why the close link between the two. And in fact, we think that there is a cofactor for vaccine-induced thrombosis thrombocytopenia, or TTS, very similar to heparin, that causes the production of antibodies. These antibodies can be detected by a variety of other testing, and majority of those tests are based on either detection of the antibody itself or a functional change in platelets, donor platelets, when exposed to these antibodies. The THANS advisory group, and THANS being a professional body in Australia and New Zealand interested in thrombosis and hemostasis, so Thrombosis Hemostasis Australia New Zealand Advisory Group, developed this algorithm for early diagnosis and management of TTS or VIT. So the first tier laboratory tests that we've done in all our patients include a platelet count and what's called a D-dimer, which is often 5 times the upper limit of normal, with a normal or a low fibrinogen. And this seems to pick up most cases in the 4 to 30 day post-vaccination. Although we specified this as 30 days initially, a subsequent sort of reanalysis and international data suggests that it could be up to 42 days after diagnosis or after the vaccination. So this is our own data from the Australian group, and we've compared it with the international data that's supplied. And you can see most patients have very low platelet counts, sitting in the 20s and 30s. They have a low fibrinogen and a very high D-dimer. And the ASEM, or the Australian College of Emergency Medicine, published their algorithm, which in conjunction with our approach to diagnosis in the laboratory, proved very instrumental in reducing the risk of TTS. So once you have a clinical concern for TTS and the patients present between 4 to 42 days after the ChAdOx1 vaccine, we'll look at the full blood count and the D-dimer. If platelet counts are low and D-dimer is very elevated, then we come to the conclusion that TTS is likely. And then if TTS is likely or suspected, the pathway was to go on to seek expert hematology opinion and other appropriate imaging to confirm the presence of thrombosis. So this is an example of a tier 1 lab test. So fibrinogen could be normal, but the D-dimer is very elevated. And if you use that in conjunction with a low platelet, it could still be a TTS. And if you look at the Australian VIT data in the first 2 months, then we have most patients have platelets less than 150, and a few patients had D-dimers at the cusp of 5 times the upper limit of normal, but majority had very, very high D-dimers, and the age predominantly was in the older age group, remembering that majority of the patients did have who did have the ChAdOx vaccine were over the age of 50 to start with. And there were a variety of sites where the thrombosis occurred, and this included in the lungs as PE, the cerebral venous sinus thrombosis, splanchnic or arterial. The second tier tests are a bit more complex and needed to be referred on to statewide referral centers. We established one in every state, or where there was none, referral pathway to another state was organized. And ELISA and functional vid testing were the key second-tier tests that were established. There was an online form created on our website, and the laboratory testing followed once the samples were shipped along with the form to the reference laboratory. So we used an ELISA-based test that consistently identified anti-PF4 antibodies, and we needed to have these tests done quite rapidly, so there was a huge effort across Australia and New Zealand to have a turnaround time as quick as possible, and these test results were often available within a few days of collection. There were third-tier tests that were available in some laboratories, and where we had some discrepancy using the second-tier tests, we often used a serotonin release assay. In some laboratories, multiplate was also available, and flow cytometry-based assay was developed by my colleague Vivian Chen, and this was rolled out in conjunction with the second-tier tests, that is ELISA-based tests, as a major third-tier test that had a quicker turnaround time than the serotonin release assay. So essentially, when a patient presented with acute onset symptoms, this was our approach. So establish the diagnosis and treat the clot. So occasionally we did have patients who had normal platelet counts and thrombosis, wherein we repeated the platelet count within a few days in order to make sure that the disease was not progressive. The second patient is a 52-year-old female who presented with headache, nausea, vomiting 12 days post a ChAdOx1 vaccine. Her ECOG was 0, essentially a very active person before she presented, and she'd had a DVT in her early 20s and had an SLE but non-active and not on any treatment. But 5 days prior to this, she'd presented to the emergency department with pain in her lower limbs, and this was 7 days post her ChAdOx1 vaccine. At that time, her blood count was bang normal, but you'll notice the platelet count sitting at 151. Her D-dimer was elevated, but the fibrinogen was also elevated. Ultrasounds of the lower limbs were normal. There was no thrombosis, and she was discharged from the emergency after a thorough evaluation at that time. But she returned on day 11, day 12, when she developed generalized headache, malaise, rigors, and headaches on day 11. And she then presented on day 12 with persistent headache and intractable vomiting. There was no focal neurology on examination at that point, and no other symptoms to suggest any other pathology, really. And she then had a blood count which looked like this, with a platelet count of 24, so all within 5 days. And if you look at a coagulation profile, this is extremely abnormal, with a fibrinogen of 0.6 and a D-dimer which was way beyond our scale. And the other testing to look for any active SLE was all oral lupus anticoagulant was negative, and a CT venogram showed a cerebral dural venous thrombosis. So we replaced blood products and commenced her on an anticoagulant called agatroban, which can be monitored using an APTT. On day 2 of admission, she developed new expressive dysphasia and ataxia, and the thrombosis had worsened, and she had developed a new bleed. And so she had to, she had to continue on agatroban and had clot retrieval under neurosurgery and neurology, and she then transitioned to another anticoagulant called dabigatran, which is oral, discharged to stroke rehab, and is progressing well. So if you look at a testing, the routine testing used for doing hits did not detect any platelet 4 antibody, but her other testing for VIT, or TTS as you may call it, was all positive. So in essential, the management principles of suspected TTS or VIT is to test for presence of anti-PF4 antibodies using specific tests that work in TTS, use non-heparin anticoagulants, avoid platelet transfusions except for bleeding or neurosurgical interventions, and consider IVIG or plasma exchange. So there are many different anticoagulants you can use if you can't use heparin, and I've listed a few there. So essentially the principles are that you use a parenteral anticoagulant followed by a DOAC. Whilst there is no evidence that heparin products worsen TTS, the similarities of the syndrome to HIT is the reason why we avoid it. And intravenous immunoglobulin seems to work to increase the platelet count significantly, and therefore it's used with those with low platelet counts and significant clot burden. Neurosurgery seems to work, particularly those with a large clot burden or cerebral venous sinus thrombosis, and when done early is life-saving. And we actually undertook neurosurgical intervention and clot retrieval in one patient on full dose anticoagulation. And there is widespread evidence and scientific literature which sort of supports this. And if there is bleeding, as there could be, in some patients with low platelet counts or low fibrinogen, we replace these and we avoid aspirin for TTS. If there's catastrophic thrombosis, we've used immunoglobulins, methylprednisolone, and plasma exchange is also recommended in some patients, and complement inhibition with eculizumab has been utilized in some cases. So the key thing is early detection, imaging, high index of suspicion, particularly if there is unusual sites of thrombosis or increased burden of thrombosis. And really a lot of education went into the GP world to advise GPs on how to consent patients and advise them about presenting to emergency early should they have headaches or other unusual symptoms. And this concludes my presentation. I'd like to acknowledge this huge effort on behalf of my local, national and international collaborators of THANS, or the Thrombosis Hemostasis Society of Australia and New Zealand. In particular, the THANS VIT advisory group was led by Associate Professor Vivian Chen, whose huge contributions should be acknowledged. In addition, the VIT ELISA group and the testing group was led by Dr. Emmanuel Favalaro, who coordinated all the testing across different sites, advising them on standardization and sample collection and transport, and so on. So you're welcome to visit the THANS website, which was updated weekly throughout last year. Things have obviously slowed down since the ChAdOx1 vaccine has moved on. And you're welcome to submit questions. And thank you, Robert, very much for the invitation. And I look forward to the panel discussion.
Thanks so much, Anoop. That was great. Now to talk about therapeutics, our last topic, but not the least. It's really important. I want to introduce Associate Professor Stephen Tong. Stephen is an infectious diseases physician with the Victorian Infectious Diseases Service, and he's co-head of the translational and clinical research in Indigenous health cross-cutting disciplines at the Doherty Institute. There's a mouthful for you. He spent 10 years in Darwin before moving to Melbourne to join the Doherty Institute some 5 years ago. Welcome and thank you for joining us, Stephen. I'm really looking forward to the last but special presentation.
Thanks very much for the introduction and thanks for the invitation to speak about COVID-19 therapeutics. I'd like to acknowledge the traditional custodians of the lands that we meet on, and for me, the Wurundjeri people of the Kulin Nations, to pay my respects to elders past, present and emerging. And this talk will serve as a bit of an update to the talk that I gave at this forum last year. I'm going to again go through the different disease stages and then talk a bit about moderate and critical ill patients, while before focusing mainly on mild and early disease, which is where probably the most recent developments have occurred in terms of therapeutics, and then a little bit of a discussion about the ongoing needs that we have for both research and data. So I think it's pretty well understood now that there is a spectrum of disease with COVID, going from almost really asymptomatic disease through to mild and then severe infections. In mild disease, there's an early high level of viral shedding around the time of symptom onset, which goes away fairly quickly as the host's immune response controls the virus. And there then isn't a kind of ongoing long-term inflammatory phase. And in fact, here it shows symptom relief by about day 15, but for the majority of patients, it's well before that. On the other hand, for those who develop more severe COVID, there's that initial high viral load and viral shedding, but that continues for longer, and there's not as much of a control of the virus during those early stages. However, then there is this hyperinflammatory phase later on in the second week of illness, which really is what drives the pneumonitis, the inflammation in the lungs that we see, leading patients to need oxygen and leading to ventilation and the need for the intensive care unit. So there's this kind of spectrum of disease, and we're understanding that the treatments that are required at the different stages are different. This is another way of showing this as we move from the asymptomatic through to mild, moderate, severe and critical illness. Early stages of the disease are largely mediated by the viral replication, and we can see that that's prominent early on. And then later on, in the more severe stages, it's more an inflammatory process once more. And so this gives us an idea of what kind of therapies we need to be targeting. And early on, it's about use of antiviral therapies and antibody therapies, which also directly target the virus. And then later on, it's more about dampening down the inflammation in the immune system and the use of immunomodulatory agents. It's worth keeping in mind that things have changed over the course of the pandemic, and that this Omicron stage that we're at the moment is quite different from Delta in the previous waves. So this is some data from New South Wales. On the y-axis here is what we call a linear scale of the proportion of cases, hospitalizations, ICU and ventilations as a percentage of the Delta peak. So that Delta peak happened in September, and so we're setting the meter at 100% at that point. And now in New South Wales, and this is early January really, the data, you can see the number of cases has skyrocketed to at least 13 times that which we saw during the Delta peak. However, what we don't see is a similar skyrocket in the patients who are hospitalised or in the intensive care unit. And so even though there's been all these large number of cases, there really has been a decoupling of the severity of disease. And so what we're dealing with now is very different from what we saw during those early waves. And the clinical trial data was, of course, mainly focused on cases during the early waves. And so we need to keep that in mind as we think about how to apply the evidence and the data that we have to the situation that we see today. So moving on to therapies during the moderate and critical illness phases. So this is where immunomodulation is of benefit. And the first real data to suggest that was from the recovery trial. And this is really from June of 2020. And they demonstrate a very, very clear benefit of dexamethasone, a steroid medication. So in these graphs, we have on the x-axis the days since randomization in the trial, and on the y-axis the proportion mortality. And we can see for all participants here, about 6,000 patients, dexamethasone resulted in a reduced mortality rate. And this was particularly true in those who are on invasive mechanical ventilation, those requiring oxygen alone, but not for patients who do not require oxygen. And so where we use dexamethasone is when patients start becoming hypoxic, needing oxygen, and certainly as they move on to a ventilator. Other immunomodulators include the Interleukin-6 Antagonists. So again, in the recovery trial, they demonstrated that tocilizumab reduced mortality compared to usual care without tocilizumab, and almost all these patients received steroids as well. And this was confirmed in the REMAP-CAP trial, which focused on critically ill patients in the intensive care unit. And if we perhaps just look at this graph here on the right, we can see the blue lines refer to patients who are off the ventilator quickly, so they have a large number of organ support-free days, whereas red refers to patients who have died or they've had to remain on the ventilator for a lot of days. So you can see that those who got the interleukin-6 receptor antagonists, there's less red and more blue, and this was a statistically significant difference showing the superiority of the interleukin-6 receptor antagonists. So this has also somewhat become our standard of care. Unfortunately, in Australia, it's been very, very difficult to get hold of tocilizumab, and so we've used this to a very little degree so far. Fortunately, there's been other immunomodulators, so what we have been using a lot more of is baricitinib, which is a Janus kinase inhibitor. This was one of the early trials demonstrating that baricitinib was better than placebo in terms of getting patients better more quickly. And this was true across the spectrum of disease. What this trial didn't inform us about was, though, it was conducted prior to steroids, prior to the recovery trial, and so these patients received baricitinib without steroids. So it wasn't really clear where baricitinib should sit with regards to patients who are also receiving steroids. So more recently, the COV barrier trial demonstrated that in addition to steroids, baricitinib had a major effect on mortality as well. So a hazard ratio here of 0.57, so a reduction in the rate of mortality by 43%. So very much baricitinib now is also considered standard of care, and we typically will treat patients who start becoming hypoxic initially with steroids, and if they're not turning around in that first 24 to 48 hours after starting the steroids, we would pretty quickly introduce baricitinib as well. Remdesivir is an antiviral agent, and so this is not one of the immunomodulators, but early trials, and this was perhaps one of the very first trials, demonstrated that remdesivir reduced the time it took for patients to get better. So it reduced the time to recovery. And this was true for patients, particularly those who are receiving oxygen, but no longer effective once patients were on to mechanical ventilation, so no difference with placebo. So this demonstrates that earlier treatment with these antivirals is more effective than late treatment when a patient's already on a ventilator. What threw the cat amongst the pigeons was the WHO Solidarity trial, which was a large global trial, in this case with over 5,000 patients, which showed absolutely no difference between patients who received remdesivir and the control group in terms of 28-day mortality. And so this gave us all a bit of pause with regards to remdesivir. And in fact, the WHO, its recommendations still are that patients not receive remdesivir, or that it's not a very highly ranked therapy in their eyes. There has, though, been then, of course, more data, more trials that have come out, and this is a forest plot where to the right of this line down the middle is where the control therapy is favoured, whereas if the dots are on the left of that line, remdesivir is favoured. This was put together by Todd Lee from Canada, and really you can see that for patients who are on mechanical ventilation, most of these dots sit on the right of the line, and so there's no benefit in that group in giving remdesivir. But patients who are requiring oxygen and not on a ventilator, most of these dots, and the larger dots in fact, are sitting on the left-hand side of the line. And in this meta-analysis, remdesivir in this subgroup of patients reduced mortality by 17%, so the risk ratio was 0.83. And I find this reasonably convincing data to suggest that we should be giving remdesivir for patients who are requiring oxygen but not yet on a ventilator. And this is another way of representing that data in a kind of Bayesian probability way. Again, if most of this curve is on the left of this dotted line, that indicates the remdesivir is beneficial. And in fact, based on this analysis, the probability of remdesivir being superior is 97%. And the probability that you would get at least one fewer death per 100 people treated is 88%. And so altogether, I'm feeling pretty convinced that we should be using remdesivir in this patient population. Moving on to mild and earlier disease. So just again, a reminder that during this early stage of disease, we're really looking at reducing viral replication with antivirals and with antibody-directed therapies. So this is where the monoclonal antibodies come in, and there's a number of these, and they've all been shown in trials for high-risk patients who aren't yet hospitalised, that giving these monoclonal antibodies reduces the risk of hospitalisation by 80 to 90%. Here is a picture where in blue is the SARS-CoV-2 spike protein, or part of the spike protein, and here are the two monoclonal antibodies which are binding to it in a non-overlapping manner. So this is the Regencov or the Regeneron product. And all the other monoclonal antibodies work in a similar manner. And as an example of one of those trials, here's patients who are at high risk and within 5 to 7 days of their symptom onset. On the y-axis is patients with an event which is either hospitalisation or death. And you can see that the placebo group, about 4.5–5% of patients required hospitalisation compared to approximately 1% of those who got the monoclonal antibody. And hence there's that kind of 80 to 90% reduction in the risk of hospitalisation. It's worth saying with Omicron that this Regeneron product actually probably doesn't work very well because of mutations in the spike protein. However, one of the other monoclonal antibodies, sotrovimab, which we've been using quite a bit in Australia, has been shown to retain its activity. Moving on to antivirals, which directly target the replication pathway for the SARS-CoV-2 virus. So one of the ones that has recently been approved has been the Pfizer product called Paxlovid, and that includes an agent that inhibits the main protease of SARS-CoV-2. So as the virus makes its viral proteins, these come out as large chains, and it requires its main protease to chop out those chains for these active viral proteins. And so if you inhibit this main protease, it's no longer able to do that. One of the other drugs is molnupiravir from Merck, which inhibits the replication of the RNA of the virus. So the RNA-dependent RNA polymerase is the target of molnupiravir. So both these drugs work in different ways, but both work to reduce viral replication. So both these drugs have recently been approved by the Therapeutic Goods Administration, Paxlovid or nirmatrelvir /ritonavir is the first drug here, and this was shown in the EPIC-HR trial to again reduce hospitalisation or death by 80 to 90%. Got a couple of asterisks there because this data hasn't actually been fully published yet, and whilst it's been submitted to the TGA and the FDA and they've given approval, most of us haven't actually seen the full data, so it's a bit hard to really know exactly who to apply this drug to. Nonetheless, in Australia, the government's purchased 500,000 courses of Paxlovid. It's given as 3 tablets twice daily for 5 days. And probably the most important thing in terms of how we use this will be the interactions with ritonavir. So ritonavir boosts the levels of the other drug, but in doing so, it inhibits the cytochrome P450s 3A. and that interacts with a lot of other medications. And every time a patient is prescribed this, we'll need to be closely checking whether there's harmful interaction potentially with other medications. Molnupiravir doesn't have the same issue. However, it does have the issue that it's not as potent, not as effective. So in the main trial, it reduced hospitalisation by only 30% as opposed to 80 to 90% with some of those other agents I've talked about. In Australia, we've purchased 300,000 courses of this, and this is given as 4 tablets twice daily for 5 days. For both these oral therapies, they need to be given within the first 5 days of symptom onset to be most effective. And so the great challenge for us will be to diagnose patients quickly, get them to a healthcare provider who can then prescribe these drugs. And it's going to be the tricky bit, I think, will be how we actually roll out these therapies in the coming months. And then back to remdesivir as well, which when given very early, again within 5 days of symptom onset, was shown in this trial to be highly effective in reducing the risk of hospitalisation or death, again by about 87% in this case. The problem with remdesivir is it needs to be given as an intravenous infusion daily for 3 days. So if you can imagine getting those oral tablets out to patients quickly enough, it's going to be triply or even more difficult to set up these IV infusions. And where we might use this more actually is in a hospital setting where patients might have come in incidentally with COVID, but they have risk factors for deterioration. This is another forest plot again by Todd Lee, demonstrating in the top non-specific therapies like fluvoxamine, colchicine, and inhaled corticosteroids, reducing the risk by about 25% in general. These antivirals, and in particular Paxlovid, by 80 to 90%, and similarly with the monoclonal antibodies and remdesivir. And you can see that molnupiravir isn't nearly as effective. And this then we can calculate how many patients you need to treat to prevent a hospitalisation depending on their baseline risk of hospitalisation. So for a lower hospitalisation risk of say 2.5%, you need reasonably high numbers of patients treated to prevent that one hospitalisation. Whereas once we get to 10% risk, then for things like sotrovimab, we're sitting around only 10 patients needing to be treated to prevent one hospitalisation. So we can start factoring this into our decisions as to what agents to use. And we can also factor in the costs of these drugs. So a lot of these early repurposed drugs are not particularly expensive, whereas things like these monoclonal antibodies are much more expensive. And so for every patient that you preventing hospitalisation, it's going to cost a lot more for these newer, more directed agents. However, because of their high efficacy, I still think that this is probably a price that's worth paying, particularly if we can identify those patients who are highest risk of deterioration. One thing, as I mentioned before, though, it is difficult to know how to apply this to our Omicron and highly vaccinated population. So I've looked at all these trials here and shown that, of these trials, basically 0 patients were previously vaccinated, and 0 of those patients were infected with Omicron. So when these trials were conducted, very different setting to what we have at the moment. And that's where some up-to-date data that helps us to risk stratify patients will be very helpful. So what puts a person at greater risk for COVID-19 hospitalisation? And this is some data from British Columbia in Canada, and recent data as well during this Omicron wave. And so compared to a 5 to 19-year-old who has a very low risk of hospitalisation, someone who's aged 80 or over is estimated to be 28 times more likely to be hospitalised if they get COVID. You can see that risk gradually reduces as the age goes down. If patients have other comorbidities, that increases the risk as well. And if you build these comorbidities one on top of the other, then that risk gradually increases. On the other hand, if you've had 1, 2, or 3 doses of the vaccine, that improves your risk. So we need to combine all these things together to understand the risk of an individual patient for needing hospitalisation. And this group in Canada have nicely done this, providing a matrix which includes number of doses of vaccine, number of at-risk conditions for the different age groups. So basically you could look at this and say, oh, look, this patient's got only a 2% risk of hospitalisation. I don't think we need to give them sotrovimab. However, if a patient has a 5, 10, 15% risk of hospitalisation, then yes, they're going to clearly benefit, and it's going to be cost effective in doing so as well. So we need these kinds of data from Australia as well. And the Immunisation Coalition, together with University of Queensland and Flinders University, have put together a similar kind of matrix. It's not exactly the same, and to be honest, I don't think it's quite as useful, but we have got some local data that helps us to, again, risk stratify by age, by the number of vaccines and doses of vaccine received, so that we can better work out who's at higher risk and who we should be targeting these therapies for. So my final slide is really, again, to highlight how things have changed. So this graph here is across time, across the x-axis. On the y-axis, here's the infection fatality rate for seasonal influenza. So that's, from old data. And COVID, in terms of its infection fatality rate, at 2 times, 5 times, 10 times, 20 times the rate of flu. And early on in the pandemic, when we didn't have vaccines, when we had perhaps more pathogenic variants, there were quite high rates, over 20 times that of flu. Whereas over time, we can see this has really dropped away, and this is a logarithmic curve, such that now for most people who've been vaccinated, or at a population level at least, the infection fatality rate is only 2 times that of influenza. So things have changed, and it's a question of whether, can you apply everything in the trials data from that early phase with high mortality rates compared to what has changed now in a population that has much higher levels of immunity and variants which may not be as pathogenic. And so that really, I guess, highlights our need for ongoing accurate risk assessment that needs to be up to date, and ideally local data, so that we can better risk stratify our patients and determine who should get what therapies. And also I think the need for ongoing clinical trials as well that allow for comparative effectiveness in these different eras. So for example, we might think about, trialling sotrovimab versus remdesivir versus Paxlovid, and trying to work out, well, which one is better in our current setting. And I think there will be ongoing need for such generation of evidence. So I'm going to stop there, and I look forward to the coming discussions with the panel. Thank you.
Well, thank you, Stephen. I'd now like to invite all of the speakers to join our panel discussion. In the style of the conference so far, I've been asking people to think of themselves in different shoes, and I'm going to do that again. You've just been elected the Prime Minister, and I'd like you to say what would be the first thing you'd do about COVID, and would it have been calling in the military sooner? I'll start with Christine.
It's an honour to be elected only the second female Prime Minister in the history of Australia, and thank you for starting with me, Robert. Look, I think the rolling out the world's largest vaccine campaign, at any time, at the same time as responding to the pandemic itself, has required a military-style operation. I think, from where I sit, some of the command control operational aspects are absolutely critical to our success, and I think that once that was sort of brought to bear with the vaccine rollout, if that's what we're referring to, it was very good. One of the challenges early in the pandemic was just very limited supply of the tools we needed, and that was vaccines, and that made the need to have a clear rollout plan, well executed plan, even more imperative. And I think possibly we've seen some of the surprises that Omicron's thrown at us in respect of shifting our response. That's probably been a bit of a challenge as well. So I'll stop there. I think military precision is always good.
A very specific question. I get asked this a lot, Christine. How much of the myocarditis is in the first few days? So you addressed that, but just repeat for us. And personally, I've given advice, no exercise for 2 days, light duties for 2, and then maybe go back to your rowing on the head of the river. But am I too presumptuous?
Well, I think, there are obviously people reporting cases of myocarditis later, but myocarditis occurs every single day in this country in people of a range of ages, before COVID even occurred. So we've got to look at the epidemiologic studies to see where the risk is. And it really is within that first 2 to 3 days. It's the most likely time for onset with myocarditis. Now, that's not to say that someone who might have had chest pain with onset around day 2 or day 3, who is sort of ignoring it, may not come in the door at day 10. But I really do believe that it's a narrow window where we're seeing the pathophysiology occur. And of course, we don't know exactly how that's mediated yet. So the second part about that is the exercise. And I think largely if people are feeling well, they should, tolerate exercise that they're able to do comfortably when they haven't recently been vaccinated. I don't tell anyone to do a marathon the day after they've been vaccinated. I think it's worthwhile having a few days where you're taking it a little bit easier on any exercise program. If you have chest pain, then, seek medical attention. Don't exercise.
Thanks, Christine. Great. A question for both you and for Anoop. So Anoop, you can start preparing. I'll ask Christine first. I've just had a text message and it's from a journalist. And he's concerned that there have been 8 deaths from the TTS. And he wonders whether, given we've given up on the vaccine anyway, why didn't we give it up sooner? That's the AstraZeneca vaccine. So I can put it another way. How many deaths have been prevented by the AstraZeneca vaccine in Australia and internationally? And do you have an opinion about whether we should still be using it?
So I might take this, Christine, if that's all right. First up, so we've had 8 fatalities in Australia from TTS-related complications. So I think whether this could have been, what is the risk and benefit? Obviously, at that time, when it was first rolled out, AstraZeneca was the only vaccination available to us in Australia. Pfizer was available in a limited fashion soon thereafter. And the evidence was weighed up in terms of risk and benefit at the very early stages of COVID infection. And Atagi and other experts had put together a very nice sort of risk assessment paper for GPs and other sort of experts in the community to refer to. And really it depended on whether your risk of infection in the community was high, moderate, or low. And when you looked at those sort of figures, which I didn't include as part of my presentation because it wasn't very relevant today, but you could clearly see that when the risk of transmission was very high, as in the first COVID wave in New South Wales and in Melbourne, the risk of death, even in younger people from COVID, was higher than the risk of complications from the vaccination. So it's a sort of a risk benefit at that point in time on what's available in the community to vaccinate versus your risk of complication. The risk today is obviously very different, and we don't have the AZ vaccine anymore. So there are other complications we deal with, but obviously the risk and benefit has changed. So it was just a matter of how we balance that.
No, that's very helpful. And I'll let Christine off because I'll ask you another question. I had 2 doses of AstraZeneca in my 50s and had a dose of Pfizer in my 60s. You can guess how old I am. Which cutoff, if any, was the appropriate one to use? Should it have been the Queensland approach of no one having AstraZeneca?
Is that for me, Robert?
Yeah, go ahead.
So look, we did have some young people with serious complications post AZ vaccine. And again, I think Victoria and New South Wales were in a different bucket at that point in time, where we already had a lot of community transmission. So it was just weighing up the risk and benefit again. But we did see people in their 30s and 40s with severe TTS syndrome requiring multiple sort of admissions, ICU admission, and left with significant comorbidities at the end of the TTS. So I think if I were to advocate for it now, I'll probably go without the AZ vaccine and consider the alternatives. But the situation at that time was a bit different, and it's hard to draw the line, particularly given the degree of community transmission that was happening in New South Wales and Victoria.
Yeah, thanks for that. Stephen, I'm not leaving you out. I'm fascinated by the difference between molnupiravir, polymerase inhibitor, and my other favorite, Paxlovid, Peace and Love. And it has seemingly 90% benefit if used within 3 days, I think, whereas molnupiravir is used within 5. Do you think the difference between them is probably less? And do you think that it might be a point where the two are used together, a bit like HIV therapy?
Yeah, they're all really good questions, Robert. So I don't have a very good answer for you because, we can only go by what the data from those trials has demonstrated. And for molnupiravir, it's 30%, effectiveness, and Paxlovid's about, that 85 to 90%. So they're of course not head-to-head trials, but based on that, most panels are recommending that molnupiravir really does sit below Paxlovid as priority for use. So you really only use molnupiravir if you can't use the other agents, such as Paxlovid or sotrovimab. There's certainly a lot of talk now about combining therapies. That's obviously been effective in HIV and other chronic infections such as hepatitis C as well. We have less experience of that in these acute respiratory infections. So I don't know what the answer there is. I think we should be driven by, the data, and hopefully people will be conducting trials which actually combine these agents. But for the time being, in the clinical setting at least, our approvals are to only use them as single agents.
Just a quick clarification before I give you a longer question, Stephen. Remdesivir, the big trial, didn't seem to work very well, especially if you're already ventilated, but you favoured it because it was helpful if you weren't ventilated but needing oxygen. Is that correct?
Correct. Yeah.
Okay. Where are you using sotrovimab? Because it needs to be used early too, and I'd love to see it used in perhaps aged care facilities, but where is it actually being used?
So it probably varies by jurisdiction. Certainly in Victoria, there's been lots of, discussion about how best to roll out sotrovimab. So because it's an intravenous infusion, it needs the nursing support and the facilities to do that. And you can imagine different, models of care. What we've generally landed on has been what we call infusion centres. So based at some of the hospitals around Melbourne, at least, patients who've been identified to be at high risk and who might benefit from sotrovimab have been offered the chance to come into an infusion centre to receive it if they're out in the community. It's been easier if a patient's already in hospital for, for example, what we're calling, they're in with incidental COVID, but they might have risk factors for deterioration. So of course, it's quite easy to give it within the hospital setting for those patients. I think we've probably could have done a lot better here in terms of how to roll it out. So getting it to nursing homes, getting it maybe through hospital in the home kind of settings where we send a nurse who's actually used to giving intravenous infusions of antibiotics and other things, send them out to someone's home instead of having to bring those people into infusion centres. I think we would have had better uptake of those drugs in that setting, but it's been logistically difficult.
Thanks, Stephen. I'm going to run from you backwards and say, given that you're now Prime Minister, what would you want to change most? We're about to finish the conference, so what are we going to implement tomorrow?
I think right now we should be prioritising the third doses for people in the aged care facilities. I think there's just a real gap there, and we should have done that from, once it became apparent that a third dose was going to be protective, and for those who are at highest risk. Probably, if I can throw in a second thing, I'd love it if in Australia we had conducted trials for non-pharmacological interventions and actually provided some science behind all the various strategies that we've done, such as masking and so on, and thinking about, even in schools, what are the best strategies to actually prevent infections and complications of those infections. But it's criticism across the world. It's not just Australia, but it would have been lovely to actually do some cluster randomized controlled trials in those settings.
Yeah. Anoop, your Prime Minister.
Yeah, look, I think the third dose would be my pick as well at the moment. I think it's very hard to redirect the defence to come into, say, for example, fill the gap in healthcare sector, but they can certainly help with logistic organisations around the country, and that's where I would sort of use their expertise. And really, yeah, my pick would be that rolling out the third dose, particularly in the vulnerable group.
Thanks. I agree. Christine, you get to be original.
Look, I think that yeah, absolutely. I mean, the message on the third dose is very clear, but I think it's also recognising that we have had a lot of people who actually have been infected, and so there's some really novel ways to look at population immunity. I think they need to be studied. Data for decision making, Stephen hit the nail on the head there. We've needed more of that. Much of what we've done has been very good, but we don't have as much empiric data to demonstrate how effective what we've done has been, because we're sort of in a situation. So let's push on. Let's not give up, I think, on the improvements that we can make at this stage of the pandemic, and the systems changes that we can try to implement, but also be confident that we are going to lift out of pandemic conditions. Certainly we're not going to be staying like this forever. Things are going to be getting better, as much as we'll still have bumps in the road.
Brilliant, thank you. Please stay with me for just 1 minute. We're concluding the session. I need to say a few things. The event is actually over, but I have to thank Christine, Anoop, and Stephen. Fantastic job. Please come in again. My co-chair, Lou Irving, who's off sailing already. So good luck to you, Lou. Stay safe and thank you. The Coalition wants to acknowledge our friends in industry at Seqirus, Sanofi, GSK, Pfizer, Moderna, MSD, and AstraZeneca. And we're also supported by BioSelect, EBOS, TerryWhite Chemmart, and Team Medical Suppliers.